1.
Okay, hello. From the Rheumatology Winter Clinical Symposium, this is Seth Ginsberg from Creaky Joints.
Jack Cush from RheumNow.com. Rheumatologists don't have the patience to say all those words, so we just call it RWCS.
Right. But I think it's important to take a step back and first say, here we are in the middle of winter in Hawaii.
Yeah.
A well-situated meeting that occurs now every year for the last 10 years. This is the decade anniversary of the Rheumatology Winter Clinical Symposium.
Yeah, this symposium has gone on a long time. It's a meeting for rheumatologists, and we have a fair number of like nurse practitioners and other people who treat arthritis patients who come here. And we cover an expanse of topics that are of interest to the docs who have to care for the patients with these particular conditions. And so we have a varied faculty, and we bring in experts from all around the globe to come in and teach us. We usually get about 200 plus docs, and what's great about this particular meeting is it's a lot of meetings are a lot of lecture, and sit and take notes, and this one is got the requisite lectures and slides, but there's a lot of discussion that goes on, and both formal in the conference hall, but boy, over lunch and breakfast and out here on the patio, people get asked more questions, get more answers. So it's kind of a 4 days of intense learning.
Yeah, but having said that, I will say the binder here is still quite substantial here.
Yeah.
This is a course book and a half.
That's it's your homework basically.
And I'm a binder guy. I appreciate a good binder.
I hope you have room in your suitcase for it.
Well, fortunately I do, because this is something this is a keeper for me. This is obviously being my first time here at this meeting, and it's a privilege, and it's really cool to be here because I can see the discussions and the chats that are happening between folks from faraway places, but also super remote places that kind of come here and make this kind of where they visit for this exchange with each other, and it's quite cool to bear witness, and also for us to be a part of as a supporting organization of it.
And the stakeholders are here, the companies who are interested in these products, or making these products and providing services to patients. They have to be here too, because they learn as much as we do.
Right, and it's definitely, when you put all the smart people together, the place that folks naturally want to gravitate toward. And picking Hawaii makes them extra smart this time of year.
So what stood out so far? We're in now the second, almost the last day. What was the highlight for you, or can you name a few?
I will say that one thing that popped for me sitting there was kind of from the back of the room, seeing a slide about the data on patients who mishandle their medicines, the biologics, and how they store it, and how only 11% of this particular set of patients store the biologic correctly. I thought was quite jarring, actually.
Right.
And also kind of seeing the room's reaction was another kind of observation I had too as well, because I just feel like that wasn't known information.
Right, and it's not not generally known. That's why it was popular at the annual meeting when it was presented. But the take home may well be doesn't really matter, because while they showed some very interesting information that some people actually keep their medicine too cold, and they think that that's from being in the crisper.
Right.
Don't put it in the crisper. Not a good idea. And some people let it get too hot, or some people actually go both extremes. Number one, the problem wasn't in the transport of the medicine home from the pharmacy to their home. That all this bad data, or if there was some bad data, came during home storage. Secondly, we don't know the consequences of that. So is there a real downside What we do know is that you'll lose the potency of these biologic medicines if they go to extremes in temperature and they stay there. So it shouldn't be on the dashboard of your car. It shouldn't be in the freezer or in the crisper, and that's why there's a lot of concern about traveling with these medicines. And the companies, they give kind of draconian rules. It's got to be this insulated thing with a frozen thing. And you know what I tell my patients?
What?
I say you don't need anything more than two things. One is, first off, try to avoid traveling with it, meaning take your shot a few days early or a week later. It's not going to be catastrophic, and get your doctor's guidance on that. Second is, if you do have to travel because you're going to be gone so long, number one, travel with not the big gigantic box or whatever. All you need is a label on the box that says your name and your medicine, and you can then take the syringe wrapped up in bubble wrap and put it in your suitcase, your briefcase, not your suitcase, but your purse or your briefcase or your carry-on, and it's going to stay dark and it's going to stay cool on the plane, and when you get to your destination, you'll keep it in a dark, cool place until you have to use it. Nobody gets into trouble, everybody does fine, and actually that's practical advice that works for everybody. But this information really is important because patients do have a lot of medicine, often stored for weeks and months, and some stockpile their medicines, and they got to make sure they're doing it right. I'll give you one more interesting bit of it. Go ahead.
There's guidance on that, to the best that we can provide on creakyjoints.org, where we've had this in focus, because the reality is, to your point, there are these rules, and there's knowledge you need to have on proper storage, but it's complicated with the labels that have lots of small writing and big pamphlets, and we really do want to just make sure folks have access to what they need to know about things like travel, and that's why this is so important. But I think the general the data that was presented this week is that there is a general mismanagement of medicine, and we can all do a better job.
I'll give you a link that I put up on our website today that you should probably send out to your patients. It's actually a new company run by patients who developed an app and a device where you can put a sensor on your medicine in the refrigerator, and you can sort of track with your cell phone whether your medicine's okay or whether you should be concerned about it or whatever. I hope it's not expensive. If it was something ridiculous, I wouldn't actually. I have a general rule for things like this: the more it costs, the less it works. But if it's reasonable and it gives people insight about how safe their medicine is, maybe a good thing to have.
So, just to switch subjects a bit, what about you in terms of interesting things that you've seen, heard, read that popped off the page to you?
I like, we have the word kahuna is a word that's often misused in common vernacular. In Hawaii, it actually means teacher. And this meeting is notable in that we invite a kahuna every year who is someone who is known for a career of teaching, if not research, and leadership in the area of lupus or rheumatoid arthritis or whatever. And this year's kahuna is Dr. Mark Genovese from Stanford. Really bright fellow, really nice man, great clinician, great scientist. Anyway, he gave a lecture on new therapies and specific newly developed therapies that are going to be, especially these oral small molecule inhibitors, of which tofacitinib was one of the first, but there are many others in development, and I think he went over those with great clarity and sort of telling us where these are going to come into the marketplace and what their strengths are, what the concerns are. So to me, that was a real strong lecture, greatly appreciated, because this is a therapeutic area that's expanding, and docs want new medicines for their patients who also want new opportunities. I'm always amazed why patients of mine who are on a medicine that's been out since 2000, and they're doing great, and they're in remission, and they've done well. And interestingly, they commonly ask me anything new. Like they want to know there's some other options out there for them that might be better tailored for them, or certainly gives them hope should they lose efficacy or something change in the future. So new therapies are incredibly important, and we're glad that we got to learn some of that here.
Yeah, and definitely I think the science is getting better, and that they're focusing and zooming in on these pathways, these ways of coming at the disease.
Oh, yeah.
The disease is, which is cool. And I think that also it's nice that there's so many folks from all different places that kind of all converge here. So where are you based out of?
I'm in Dallas. I'm at I do my research with the Baylor Research Institute in Dallas, Texas, and I have a practice there with Dr. Catherine Dow and Dr. Rachel Tate, and we and Leilani Law as a nurse practitioner has worked with me for 20 years. So we really we're blessed. You know, we have a great place to work. We have great patients. We got a good staff. We think we make a difference, and we also like it when we don't make a difference. Patients remind us when we don't, and it sort of urges you to do a little better, and that's humbling, sobering, makes you better, and everyone should be about getting better.
And I hope the patients are by and large respectful, and conscious. And I know that as folks come into the doctor, they're quite vulnerable, and they're in a position of need for help. And two, I think the system, unfortunately, we know all too well, makes it really difficult sometimes. And there are challenges that, patients just inherently face accessing the stuff they need. I was intrigued as well. I wanted to ask your opinion about some of these different blood tests and biomarkers and things that are now kind of becoming known and available and things like that. What is it that you're kind of seeing there, and where's that going?
I think that the newer tests that are being used in rheumatology have gotten greater specificity. We now know that patients can be diagnosed with rheumatoid arthritis with one of 4 different tests, as opposed to the old traditional rheumatoid factor.
Right.
But I think one of the biggest problems that I confront is patients are inappropriately led to believe that the tests are the diagnosis, and the diagnosis is something that actually is really established by a pattern of symptoms and findings, and then confirmed by the labs. And of course, doctors are to blame for this over-reliance on labs, because we always say, let's wait till the labs come in. We'll call you when the labs are back, and it's always like we're waiting on the labs to know what to do, when in fact the labs are often done for safety reasons,
right,
and sometimes to to alert us to some other new concern. So there needs to be better communication about labs. I wrote a blog that I think people should look at, which is patients believe their labs more than they believe their doctors, and it explains the whole phenomenon, and it lets doctors know that you need to set expectations with the patient about what labs are going to do for them.
If labs, blood work, blood tests, aren't necessarily appropriate for diagnosis, and to paraphrase what you're saying, perhaps there could be a role for them in the achievement of your notation of remission.
Right.
Is there
Absolutely.
Is there a room there? Is remission an area for?
Yeah, I mean, someone who looks good, someone who looks good by labs has got a really good chance of looking good in real life.
Okay.
Labs are in many ways a general assessment of unwellness, but if your labs look good, yeah, you've got a much better chance of having your inflammation at an all-time low, and your how you feel at an all-time high. And so so it should confirm remission. It should, but not always, because and the labs they're not always as smart as we want them to be. But again, that's a good step. And the other thing is should also be, maybe more importantly, a confirmation how safe you are on what you're doing. People should always be reminded that what we're doing is the right thing, and that it is safe. And what patients often don't recognize when it comes to taking a new therapy, all the danger, all the worry, all the real concern happens really in the first few months. although we continue to do labs all the time, I tell my patients after their first year, listen, you've done great on this injectable medicine. You don't need to worry about like the cancer infection stuff anymore. If you were going to get it, you'd have gotten it 6 months ago.
Okay.
And that message often isn't given out well enough, but we still have to do the monitoring,
Right.
even though the odds of those untoward events would actually still exist, but they're much, much less.
So basically, there are a lot of places for labs in the treatment paradigm.
We're going to do them, but I think there needs to be better dialogue about them, because I think it's unfortunate that we send them. I mean, I give all my patients, I give them today's note that I saw them, I give them a medicine list, I send them the labs. You know, some people actually know what to look at. Some people are just worried by things that are out of range. And that's not the right approach. They need to get a little education about what's important, what's not important, what's the doc looking for when he does a lab. So they're going to feel good either about how good they're doing or how about how safe the medicine that they're taking is.
And also now to switch gears a little bit more, I'm interested in your what's your favorite PRO? What's your favorite patient-reported outcome, or where, does Dr. Cush feel happiest when patients are sharing it, and what is that all about? We'll talk about that.
I think that fatigue needs to be always asked about and always quantified, because that's, we're in the pain business. We're always going to be talking about pain, but often fatigue is unrecognized, and I think that needs to be translated between the patient and the physician. I think the often used in many practices is the health assessment questionnaire, 8 or 10 questions where you check
the HAC.
The HAC score. You check one of 4 boxes about 8 things you can do, whether you have no problem, some difficulty, much difficulty, or you can't do it. I can look at that one graphic and immediately get a gestalt on how well you're doing or how well you're not doing, and then I can also incorporate that numerically into scores that I track over time in how patients are doing. And then the last PRO that I find incredibly important and usually neglected is sleep. Sleep becomes the big magnifier of all problems. Whatever is wrong with you, if you're sleeping bad, it's going to magnify that one thing, whether it's a headache or a hangnail or your arthritis.
I thought you were going to say hangover.
Well, a hangover is something you should also be talking about with your doctor, but we don't really have a good measure for that other than blood alcohol level.
Yeah, well, on the subject then of things that we should be talking more about with our doctors that we're not, and where we need more evidence and science is like kind of the family planning, the regenerative, the whole
reproductive health. Right.
And these various diseases, because there is an interrelation and there's more knowledge.
Well, the good news is that through efforts that I was lucky enough to be involved in through the ACR's Drug Safety Committee, and we had a meeting about drug safety, we had a meeting about reproductive health, and we got input from all the stakeholders. And now the ACRS has setting up a guidelines committee to look at reproductive health, to examine issues regarding the education of the patient, how to have discussions about contraception, when to have those discussions. Do you discuss the person's pregnancy potential for the future at the first visit, second visit, or is it an ongoing discussion that always needs to be dealt with in women of childbearing age? Great concern. A majority of our patients are women, and a lot of them are of childbearing age, and yet this is the most neglected area of patient care, and it would be really helpful to have guidelines coming from an expert society. The EULAR actually came out this week with guidelines on reproductive health, so that's a start.
Yep.
The ACR will add to that. I think that at least we're seeing things going in the right direction. And really, what has brought this to the forefront is patients speaking out, like, I can't find good information about what to do in my situation.
Exactly, and I think having the guidance out there for doctors from a treatment recommendation and evidence-based perspective is crucial. And I'm thankful now that I understand, as we know how ACR, for example, creates their guidelines. It's a really important process, and and there's also kind of the patient need for that kind of understanding and the ability to kind of access that information, and an area where Creaky Joints is, I know, very focused to, put patient guidelines together that's patient focused and easy to navigate, because a lot of the science and kind of treatment guidance is obviously very technical, and there needs to be interpretation for patients, and it's got to be around lots of areas. Family planning, reproductive health, obviously one of them. Vaccinations, another crucial one.
Right.
I mean, there's talks.
Kevin Winthrop's talk, yeah, was really good.
Which could you summarize in?
Kevin Winthrop is an infectious disease specialist who's very much tied into rheumatology and does a lot of instruction. He's worked for the Centers for Disease Control. He gave a lecture yesterday on infectious issues, including vaccinations, showing us that we are, as a group, doctors not very good at getting our patients to be vaccinated, and that he covered the issues around patient fears, including mercury and autism, and that you'll get the flu from taking the flu vaccine, and that I have an ag allergy. All those are actually wrong, and have been disproven by very, very reputable authorities. But unfortunately, there's a lot of misinformation circulating around this. Certainly influenza, really everyone needs to get really good data and new updates on procedures for vaccinating people with against the pneumococcal infections, the Prevnar 13 followed by the Pneumovax at some point. And then the use of the shingles vaccine, also the main impediment there being funding for those under the age of 60. And there are many people with lupus and rheumatoid who are immunosuppressed and might need to be on those vaccines, but it's a live virus that you can't take until you're off of your biologic. You can take it if you're on your methotrexate or hydroxychloroquine or sulfasalazine or even prednisone, but you can't take it if you're on an injectable biologics or the new drug tofacitinib. So again, the guidelines are always being updated. It's good that we have experts like Dr. Winthrop out there beating the bush and fanning the fan that will get the word out. It unfortunately is something. It comes at the end of the visit in most cases when everyone's good. Let's get out of here, and when you bring it up and the patient's reluctant. The doctor doesn't have the energy to sit and do all the explaining, so there needs to be more information. But I want to go back actually to the patients and the pregnancy guidelines. The ACR in its last guideline on how to do surgery, they combined themselves with the hip and knee orthopedic surgeons, but they also had I think a subcommittee of 13 patients that were involved in that process. And I believe that when it comes to this, there's going to be a patient group in this, and it's going to be very important in developing not just doctor guidelines on pregnancy, but also patient information. Absolutely, and I think that's 100% the direction it's going, which is great. And having been a part of that personally as well with ACR's RA treatment guidelines as a panelist, having understanding of both sides of the process is super important for ways to advance it. And the information's coming. I think that's kind of another takeaway. The knowledge is being gathered. The studies are being conducted more and more efficiently. Technology is making that certainly possible. And it's meetings precisely like these and the output that help us understand more and more and more. Because I'll ask you how long have you been involved in rheumatology? Oh, I started as a fellow in 1984 and been sort of legitimate in a rheumatologist since 1987. Right. So this is coming up on my 30th year. Where are you from originally? I'm from Long Island, New York, West Sayville, and I trained in Brooklyn at the Coney Island Hospital. And so around the time you started rheumatology, was there a baseball team that was doing all right? Did they have a... Gee, I hope you're not a Yankee fan, are you? Just asking. Yeah, well, the Yankees won everything all the time, nonstop. Except for 1969 and maybe another year or two. I grew up a Met fan, but all my family and friends are Yankee fans. Right. So, but now I'm in Texas. I've become a Ranger fan. So, of course, my family won't talk to me anymore, but that's okay.
Well, you could take the guy out of New York, but can you take the New York out of the guy?
No, still looking for pizza.
All right. Well, let's conclude with RheumNow and what it is and your role and
Oh yeah, thanks. Well, RheumNow is just a website that I have. It's written for rheumatologists and doctors, but we have 20% of the people that follow us are patients, and it's daily information about what's going on in rheumatoid arthritis and lupus and scleroderma and all the things. And I think patients find a lot of good information from it. So
it's phenomenal.
Yeah.
And Creaky Joints is pleased to both be a follower and a fan and a supporter of
absolutely, we appreciate that.
What you're doing, because it's key to just translate what's going on, and help us understand things. And you're masterful at that, and have a good eye for it. So thank
well,
you.
as are you. Getting the word out is what we do.
It is.
All right. So to ask your doctor, did you go to the RWCS meeting in Maui? And I saw a video. It was actually quite good. You should think about going.